Welcome to today's May 2nd AOS webinar. We have our friends and guests from NACCHO. We've got Tim McCall coming in from NACCHO as well, and also Aaron Alford. Let's do some quick introductions before we go ahead and get started. Aaron, would you like to kick us off?
Hi, Aaron Alford, Senior Director of Research and Evaluation for NACCHO. I've been at NACCHO for about 3 months longer than the pandemic, so about 3.5 years.
Wow, what timing. Thanks for coming on. And
Yeah.
Tim?
Yeah, it's nice to talk to everyone. I'm Tim McCall. I'm Director of Research at NACCHO, and I started in the fall of 2021.
Wow, okay. Well, thanks for coming in. We're very grateful and to be able to have Tim and Aaron come into the webinar today. This is something that many of our AOS state groups have been discussing throughout the past 6 to 12 months. It's an issue that's very near and dear to us as we've gone through the pandemic. We saw quite a few different issues, and when we saw this study come up, for those that don't know a little bit about NACCHO, and I know about half of our group have never had the opportunity to engage or learn or had any involvement with NACCHO, we're going to start off with doing a quick overview of NACCHO, and then we're going to get into the study and kind of talk about what Aaron and Tim were able to discover. And then if you have any questions, please put them in the chat. And if you're liking the beret, I'm down in South America today. My family's from South America. My wife's family is down in Uruguay. This is called a buena down here. And I'm on the border of Argentina and Uruguay visiting family. So we're out horseback riding across the countryside yesterday. So I felt it appropriate. So welcome. And Aaron, I'll let you start.
Good morning. I'm going to talk today a little bit about the harassment of local health departments and their staff during the pandemic. I'd like to start off, first of all, calling your attention to the list of names in the lower left. We're going to have a couple of slides that have names. This work has benefited from both NACCHO staff and then folks that we've collaborated with across the country, including some university professors and consultants and graduate students. So you'll see their names sprinkled throughout this slide deck. Tim, if you give me a slide, please. So just a quick bit about NACCHO. We are the association that represents local health departments across the United States. And our core mission is to improve the health of communities by strengthening and advocating for those LHDs. And Tim, if I could just have all the bullets, that'd be great. Thanks. So we focus on the 3,000 or so LHDs in the US, and that does include tribal LHDs. And our members are the LHDs themselves, and then all of their staff. And then we have affiliate members, which are a range of different kinds of people and organizations. Any individual can become an affiliate member under the right circumstances. And then lots of different companies are affiliates either for business purposes, business development purposes, or just to have access to our network. Slide. So early in the pandemic, at NACCHO, we've very quickly picked up on the fact that lots of folks at local health departments and the departments themselves were the subject of various kinds of harassment and political violence. And Tim, if I could just have all the bullets, that would be great. So we figured out pretty quickly that these events were widespread, frequent, and of many types. And as best we can tell, this work is one of a kind at this point. There have been no other national estimates of prevalence of violence against local health officials. So the other thing that became very apparent early on is that this violence and harassment is not without consequence. It has deep impacts on the functioning of health departments. It has deep impacts potentially on the mental health of individuals. And as a consequence, has potential strong impacts on staffing in a field that already has difficulties with staffing. Slide, please. So thus far, we have either funded or led 5 studies, but we're going to talk about 4 of them. And those 4 studies are drawn from 3 different data sources. The first data source is NACCHO's 2020 Forces of Change study. This is a survey that we've been fielding for quite a long time now. And we branded the 2020 fielding of it as our COVID edition. So it has lots of timely measures around COVID, including measures of harassment for local health officials. So study 1 was to take that data and see if we could derive a national estimate of harassment for local health departments. And then the second study is intended to understand if the characteristics and environment of health departments is associated with harassment. The second data source is the PHWIN survey from the de Beaumont Foundation, which was fielded in 2021. And so the intent of that study was to see if we can understand if harassment had any impacts on the well-being of individual staff and their intent to either stay or leave public health. And then the third was a series of focus groups of local health officials across the US. And the intent there was to see if we could understand the range and impact at the personal level of these forms of harassment. Slide.
So I will go ahead and get started talking about studies 1 and 2, as Aaron mentioned, with the Forces of Change study that we fielded in the end of 2020. So there are approximately 2,800 agencies or units that meet the definition of an LHD for purposes of surveying within our R&E department. And some states have a public health system structure that includes both regional and local offices at the state agency. So in those states, the state health agency can choose whether to respond to the survey at either the regional or the local level, but not both levels. So for this study, a total of around 2,400 unique local health departments were surveyed on a variety of measures, as is probably no surprise to anyone in this room. During COVID, response rates were very difficult to get high levels for during the pandemic response. And we had around 1 in 4 of the people that we contacted at health departments respond. And some of these questions included experiences of harassment and staffing changes due to conflict between the public and political leaders, as well as the agencies. And we first got this survey out about 7 months after the emergency declarations began. And this was in the field for a little bit over 4 months. And just something to note as we're sharing these statistics and data, we use weights in our data to adjust for differences in jurisdiction size, the way that we're sampling, as well as in the levels that different health departments respond, so that we can provide nationally representative estimates describing this data. So with a little bit of that context about what our data source was and when it was fielded, we'll get into some of the initial findings related to trying to understand a national estimate of the prevalence of harassment in the first year of the COVID-19 pandemic. So nationally, more than half of local health departments reported that either their agency leadership or personnel within that agency experienced harassment in that first year because of their COVID-19 response activities. And this did vary by type of governance, which Aaron will talk about a little bit more in a couple of minutes. But specifically, we saw that state-governed local health departments were less likely report experiencing harassment. Around 3 in 10 state-governed health departments were reporting that they've had some type of instance of harassment versus approximately 70% of agencies with a local or shared governance structure. When we first sent this survey out at the end of 2020, since similar work had not been done by all of our views of the national landscape, we really had to sort of consider what the breadth of these types of harassment could be. So this was our best guess at trying to get a range of different harassment that was experienced by LHDs. We asked lots of different items that our LHDs and personnel may have been experiencing. And the most common form of harassment targeting the agency's leadership or staff was negative messages and backlash on social media, which probably comes as no surprise to anyone. More than half of LHDs were reporting that either their agency or their staff were targeted in this way. And although we don't show this on this graph, large LHDs were most likely to experience direct messages and threats to an individual, as well as information being broadcast about their staff members, their personal information. This is also called doxing. So as I mentioned before, this was really our attempt to try to get at the range of harassment that was being experienced. And you might notice when you're looking at this slide that some of these really come at a personal low risk to the perpetrator of harassment. So internet backlash, signing onto your computer, firing off what could be a hateful message or a mean message, although sometimes threatening messages. But then other ones that are less common on here come at a higher personal risk to the perpetrators of harassment, such as vandalism or going to a local public health professional's house and making threats or leaving items at their house. So we'll revisit later in the presentation whether we got this range quite right as we started to explore more about what the harassment is looking like at the local level. One area that we were particularly interested in early on with the reports that harassment was likely pervasive as we were collecting this initial data was whether or not local health departments and their staff were receiving any form of protections in the face of this unprecedented harassment. And of the local health departments who did report instances of harassment, around 2 in 3 did not receive any form of protections from federal, state, or local entities. And the most common source of protections of those who were receiving some type of protection was from local entities. But notably, no local health departments that experienced any of these harassments or threats were receiving any protections from any federal entities. And as the COVID-19 response raged on in that first year of the pandemic, reassignments of staff and firings at the LHD level because of conflict between the agency and public or political leaders we know was already occurring. We've heard in the 3 years since the pandemic began that this is becoming more and more commonplace. But just in that first 8 or 9 months, almost 1 in 12 local health departments reported that there had been reassignments or firings at their agency because of conflicts between their agency and the public or political leaders. We were interested in this first data set, just really sort of exploring some of these relationships of experience of harassment. So I just mentioned, that 1 in 12 local health departments were describing that someone within their agency had been reassigned or fired due to conflicts between their agency and the public or political leaders. And this did not come as much of a surprise to us, only it seemed as though there were certain LHDs that this was more likely. And as you can probably imagine, and I'm displaying that on the slide right now, agencies, leaders, and personnel who reported experiencing harassment, there were higher odds of there being reassignments or firings at those agencies in particular due to those conflicts between public and political leaders. So these were some of the findings that really gave us an initial sense of how pervasive this was happening, or how pervasive this was in the first year of the pandemic. And we knew that even though it was widespread in that first year of the pandemic, and it has since continued, most jurisdictions didn't receive protections from federal, state, or local entities to combat this harassment. Almost 1 in 12, there were actual reassignments or firings due to the conflict with the public and political leaders.
Yeah,
And there were higher odds of that happening among the agencies who were experiencing harassment. Aaron, I'll send it back over to you.
The second study that made use of the forces data was focused on attempting to understand if the ecology, if you will, of the local health departments was associated with harassment. And in particular, given the circumstances, especially of the first year of the pandemic, we were particularly interested on whether or not the characteristics of the local health official had anything to do with harassment or had any association. And then we were interested in understanding if the inequality of the state in which the health department is housed had anything to do with it. And then we were interested in state politics. Because early on, we heard that while there were certainly things happening locally that were driving some of the harassment, that there was a sense that it was the broader ecology, especially the political ecology of the state, that seemed to be driving the harassment. So we're using a logistic regression where the dependent variable was experience of harassment, and this was dichotomous, yes, I have experienced, or the health department has experienced, or no, we haven't. And the independent variables were the presidential election outcome for the state, several LHD and health official characteristics, and then the Gini index, which is a measure of inequality at the state level. We found that LHDs that were led by women or BIPOC leaders had lower odds of reporting harassment. This caught us by surprise. Qualitative work that we've done has indicated that folks with those characteristics tend to experience more harassment in medical settings. So this is didn't track with prior findings, so not sure how to explain this. I think probably the easiest thing to think about is that the characteristic of the leader did not track with the full experience of the health department, right? So we didn't ask the leader if they had experienced the harassment. We asked if their health department had experienced or if their staff had. So I think that might be probably the best we can get at, is that the characteristics of the leader did not shape the whole experience of the LHD. However, another counterintuitive finding that tracks in a different direction, we found that states that went for Joe Biden in the 2020 election had higher odds of reporting harassment. And we found that this interacted with governance. A feature that we hadn't thought of, and it wasn't until we had the analysis done that we went back and we're trying to figure out some explanations for this political finding, and especially the interaction with governance, where local LHDs are more likely to experience harassment than state-governed LHDs. We figured out that 19 of the 20 states that we currently have characterized as centralized governance also went for Trump in the 2020 election. So whether or not at their founding they had common characteristics, in the current state, centralized states tend to, at least for national elections, go for the Republican Party. Next slide.
So those were some of the data that we had from our initial forces of change data set at the end of 2020, beginning of 2021. And our next study gave us a unique opportunity to examine some individual level data, where most of our surveys at NACCHO use local health department as our unit of analysis, meaning that we're usually asking questions about the agency as a whole. De Beaumont Foundation every few years fields a national survey to local health professionals and state health professionals across the country. And they gave NACCHO early access to their nationally representative data set that they collected last year, so that we could examine some of the issues that were facing local public health staff. So the study that I'm going to talk about now, it's been published in JPHNP, and I'm going to summarize our process and our findings. It's called The Role of Harassment and the Mental Well-Being in local public health professionals and its relationship with intent to leave their organization during the COVID-19 pandemic. So understanding some of the questions that the Beaumont Foundation fielded to public health staff across the country and the data that were going to be available to us, we had a couple of questions that we were interested in exploring. The first was, does experiencing outside harassment predict the level of mental and emotional health among local public health professionals? And the second question that we were interested in exploring was, does experiencing outside harassment predict those staff considering to leave their organizations for other opportunities? So the De Beaumont Foundation PHWIN study, it's the Public Health Workforce Interest and Needs Survey. I'm going to spend a little bit of time talking about the methods. It's a rather complex process of getting all of this data from public health professionals across the state. And we're going to be focusing on a subset of that data today. But to give everyone their bearings, this is a nationally representative sample that we'll be describing today of around 27,000 local health department staff members from almost 440 local health departments. This sample includes local health departments that have more than 25 staff members or whose population served is above 25,000. And as I mentioned, our survey instrument here is the PHWIN study, which included a battery of questions, but some of those questions included workplace environment and well-being, as well as COVID-19 response, training needs, ways to address public health issues, and also basic workforce characteristics and demographics. Another important note, as we're describing these results, the sampling methods of the PHWIN survey is a stratified sampling method, so that depending on the region of the country, it samples from and weights for 10 different HHS regions, as well as whether the jurisdiction is a large jurisdiction above 250,000 or a smaller jurisdiction below 250,000. Oh, sorry. I'm showing this slide so that everyone can actually see the results that we're going to be presenting today. So you don't have to pay close attention to this, but it's important to know that PHWINs goes to both state health agencies as well as a combination a random sample of local health departments who are members of the Big City Health Coalition, and also all local health departments in HHS regions 5 and 10. Today, we're going to be presenting those results specifically on the nationally representative sample of the local health department staff, which is in this blue box on your slide. However, the full PHWINS data set does include state agency respondents as well. So in that long survey that I mentioned, PHWINS has all sorts of data. Here are the 3 variables of interest that we were able to use to explore our 2 research questions that I'm going to revisit in a second. There was a question on whether or not staff had felt bullied, threatened, or harassed by individuals outside of the health department because of my role as a public health professional. There was also a question on, in general, how would you rate your mental or emotional health? And this was rated on a scale, and we dichotomized it as positive or negative, as you'll see on your screen. And then there was another question that asked respondents whether or not they're considering leaving their organization within the next year. And if they are, what are they planning to do? Is it to retire, to further their education, or to go to another job, either within public health or out of public health? Or finally, are they just planning on leaving the workforce entirely? So using these 3 questions, we were able to consider our research questions, which I'm going to revisit one last time to explain how we have tested our hypotheses related to this. So in terms of wanting to know whether or not agreement with experiencing harassment predicts levels of mental or emotional health, we conducted a binary logistic regression. And then for our second question of whether or not experiencing outside harassment predicts whether or not staff are considering leaving their organization, we used multinomial logistic regression, which I will be displaying on the upcoming slides to really understand, okay, is harassment predicting mental and emotional health? And also, is harassment predicting whether or not local health professionals are planning on leaving the workforce or leaving their organization? So some of the initial results that we found before we really dove into those statistical models was trying to understand how many of our local public health professionals were saying that they've experienced harassment and bullying. Almost 1 in 6 local health department staff agree that they've experienced harassment and bullying. And you might notice that that's a bit different than the forces of change data that we described. Part of the reason that we think this is different is this survey was focusing on all levels of staff within agencies across the country. So around 15% of all staff, not just leaders of an agency, were saying that they have experienced harassment and bullying because of their role. Whereas our forces of change survey was saying, is it someone or your agency within the agency experiencing harassment? And we find those higher numbers. We also found that over 1 in 5 local health department staff were reporting negative mental or emotional health. And finally, almost 1 in 3 local public health professionals were reporting an intention to leave their local health department in the next year, which is an alarming number, given that we are already facing staffing shortages in the midst of COVID-19. So let's talk a little bit about those research questions that we had in particular, whether or not experiencing harassment predicts your mental or emotional health from our respondents. And yes, harassment was associated with poorer mental or emotional health. So the odds of reporting positive mental or emotional health decreased by 36% for every increase in agreement that they've experienced harassment, threats, or bullying because of their role as a public health professional. That next research question we had about whether or not harassment was predicting LHD staff considering or intending to leave their organization for other opportunities, it was associated with higher risk of leaving the workforce, leaving for another public health job, leaving for a non-public health job, or pursuing further education. So I show here the slides that this was true for every change in the workforce that could be intended other than retirement. So there was higher risk of doing all of these things the more that you agreed that you were experiencing harassment because of your role as a public health professional. So to sum up some of what I've just described, more than 15% of our local public health staff experienced harassment during the pandemic as an individual, not at the agency level, but 15% of our hundreds of thousands of public health professionals in this country were experiencing this. And respondents who indicated that they did experience harassment were reporting poorer mental or emotional health than those who weren't experiencing harassment. And finally, those who were experiencing harassment had higher risk of intending to resign from their current local health department, with many intending to exit the public health field altogether. It's always important for us to discuss some of the limitations of any study that we do. This, just like the Forces of Change study, these data are self-reported and they are measured on subjective scales. The other thing to consider is that an intention to leave might not result in actual attrition. On the converse, however, there are people who may report that they're not intending to leave currently that may ultimately leave as well. And, the proportions of local health department staff who say they've experienced harassment may actually underestimate its occurrence. One of the reasons being that this survey only includes respondents who are still at an agency and chose to respond. So this may exclude other burned out local health department staff or those who have already left the local health department for any number of reasons, including that they could have experienced this very harassment that we're interested in quantifying. The final thing is, as I mentioned when I was talking a little bit about the sampling, this is a nationally representative survey of health departments that have above 25 staff and that serve more than 25,000 people in the jurisdiction. So it may not generalize to local health department staff that are in smaller jurisdictions. And for our last study, I will send it back over to you, Aaron, to talk about some of our recent work.
Thanks. So for this study, I just want to call attention to Jordan Royster. His name is here on the slide. This work was pushed forward by the whole team, but some of the insights we're presenting here were really developed by Jordan and by Margaret Cunningham. So the final study was a long time in the making, but we knew that the quantitative studies were giving us a signal that was interesting, but was lacking a lot of detail. So the intent here is not to come up with a nationally representative image of rates, but to help us understand sort of the depth of impact and the breadth of harassment, if you will. Next slide, please. So core question is what was the range, severity, and source of harassment? And then very interested in the impact and responses to harassment. I think going into this, we thought we were going to arrive at lots of lovely policy solutions, but I think the having captured the impact of the harassment and the just the human toll probably was the most important outcome of this study. Next slide. So we set out to do 4 virtual focus groups. We knew that we needed to capture folks who had experienced harassment or had reported that their staff members had. So we undertook a sampling regime based on responses to the 2022 profile, where basically we gated folks into a sampling schema based on their report in the profile survey. Next slide, please. So 2 independent raters set out to code the transcripts from these focus groups and came up with a variety of themes around context, effect, aggravating factors, protective factors, and possible solutions. Slide, please. So I just want to call attention to this. I think at the end of the day, folks gave us lots of interesting things to think about. We have a paper being led by Jordan at the moment that lays out some of the things that we found. But for me, these are the sorts of things that I took away. So this is pretty shocking to me. Still, every time I read this, I find myself shocked. These are folks who most of them have spent their careers laboring away on behalf of the public's health without reward other than a good job, good place to work, and the satisfaction of knowing that they're doing good work. Almost overnight, these folks were vaulted into the limelight and had these sorts of behaviors focused on them. Next slide, please. So when we set out to do all 5 of the studies, the 4 described here and 1 with the Bay Area health officials, we had some strong preconceived notions, especially those of us who were at NACCHO early in the pandemic response. I remember a time in, let's say, March, April of 2020, when we were starting to put together Excel spreadsheets and any other form of tracking that we could of reports of the health officials that were leaving their jobs and or reporting personal attacks, familial attacks. And so at that time, this was largely a backlash from a particular flavor of folks who had a particular political viewpoint. However, as the pandemic response evolved, we started to pick up a different signal. And I think for our team, we hadn't quite realized that the signal had changed. So we went into this study and the other studies sort of expecting to pick up the same signal as early in the pandemic. And that's not what we found. And so this slide for me is a great reminder that lots of different kinds of folks were committing this harassment, and for a lot of different reasons. And so, you know, you've got everything from animal rights groups and anti-vax groups, and those anti-vax groups are not a monolithic block. Those are folks on the left, right, and then on the libertarian spectrum as well, who, for a variety of reasons and often different reasons, had strong qualms with vaccination orders and all things vaccination. Next slide, please. So at the end of the day, one of the signals that we keep picking up in every forum that we present this information and ask for feedback, and then also in the work itself, is that local health departments were blamed for the mistakes and held accountable for the grievances around decisions that were made by regional, state, and national authorities. And very often those LHDs had no policy power whatsoever, no authority over the things that they were enforcing. However, the local health officials and their staff became the face of public health. And so as the local face, as the person who was closest by and most visible, they also became the targets of harassment. And here's a quote taken from study 4 that I think really characterizes this. And this was from a local health official who had basically become the face of national and state orders as a result of having to communicate to her local public on behalf of public health. Next slide, please. So a variety of recommendations have come out of this work. The first is that there's a great need for long-term and flexible federal funding that is specifically for LHD, targeted at reducing turnover, mitigating loss of institutional knowledge, and in general, increasing the resilience of the public health workforce in preparation for future emergencies. There's definitely a need for training local health staff in very practical ways about how to respond to harassment and then cope with the resulting stress. And then finally, there were very few protections in place, and there is a very strong need for federal, state, and local protections of the local health department infrastructure and staff. Slide, please. So as we present these findings in different forums, one of the things that has come to the fore and has come to the fore out of the qualitative work is that the trauma of harassment and the trauma of the COVID emergency response persists. As the nation itself opens back up, as we have turned away and kind of gotten past COVID, that the staff members and departments haven't begun really dealing with the trauma and personal costs yet. And so there's a really huge need for funding, expertise, and support for local public health staff, and also for their families and those that they relied on during the response. It also seems to be that there's a need for communication campaigns to help reorient the public, because despite the perception that public health failed, public health didn't fail, right? We all know, everybody on this call knows that this could have been way worse, and that it is the efforts of public health and medicine that turned the tide on this. However, the public doesn't feel that way. And so one of the signals that we picked up, especially in the qualitative work presented, is that folks who experienced harassment are living in communities that feel that they failed, or at least where some portion of the community feel that they failed. And that those same folks who were threatening their children are still going to church with them. And the folks who threaten their staff and the lives of their staff are waiting on them in restaurants and in line with them at grocery stores, and still communicating their anger and mistrust. And so there's a need to turn the tide there at the social level. Another thing that we learned from our qualitative work and from presenting this in a variety of forums is that there are so many very basic things that we have not thought of as a field that other fields have dealt with frequently. So, for example, Planned Parenthood has been under assault for decades. They know basic things about how to advise their staff on what kind of security cameras are best for your home, depending on where you live and what your circumstances are. And there's a whole lot of that information that I think we need as the field to harvest and then make accessible to local health departments and their staff. Next slide. Thank you. That's the end of our formal presentation, and we'd love to hear from you. And I guess the other thing I would also say here is we've presented this in a lot of different forums thus far, and it is very clear that discussing this with folks who've lived through it is very traumatic. And I hope that if anyone finds themselves re-traumatized by this, that you will reach out to for help and support, because this stuff it's not easy. And I think as a field, we're going to be recovering from these experiences for a very long time.
Well, thank you. Thank you for coming in. I know for those of us, we're going over numbers, but to many of us, these are people, these are people that left our groups, left the profession. And as you go through those numbers, I keep thinking about various individuals. I think from a data collection standpoint, I mean, this is a very different audience probably for NACCHO, in that the vast majority of our AOS members are the grounds level of collecting, and we're involved in COVID data collection efforts. For our members, if there's any questions, please put it in the chat. Louise from Utah, our Utah AOS group member, put in and said, have you reached out to any other countries besides the US to see if there's similar studies underway in other countries? That's a great question, to see if there were, or if we've known of any.
Yeah, we've not attempted to do that. It's a great idea. We've certainly scoured the literature and tried to keep abreast of literature in this space, but we've not seen any national estimate.
Marcy has a comment in there as well. The one thing that I would add, and I liked that comment, is it is hard to study somebody that is left, right? These are survey results of people that are currently in the health department. And as I look through those numbers, for those that don't know nationally, AOS, we have about a 35 to 38%, depending on the state, of AOS members that left during about an 18-month period. Obviously at AOS, it's easy for us to know who left because we're making AOS member changes. And many times they were very difficult conversations on the phone. Hey, Jake, I'm getting out. And, maybe I was kind of the person they got to talk to. So that's why it kind of hit home so many times. But Marcy has a question. She says, I think there's a need to study the physical health impacts related to the pandemic response and harassment. There are many of us that are experiencing physical repercussions as a result of the stress and harassment. Neurological symptoms, cardiac symptoms, intractable, and so on. Not long COVID stress related.
So Marcy, thanks for that. The cost has been terrible. At our national conference, I talked to a fellow who had done some great survey work with preparedness coordinators at local health departments. And one of the measures that they fielded was a clinically valid measure of secondary PTSD. And they found that 60% of all of the folks surveyed had significant symptoms of PTSD, and then well over 30% had symptoms that were so severe that they could reasonably be expected to impact family functioning, work life, and general life functioning. And so that's really more on the mental health and behavioral health side, but I think that level of response and then that prevalence shows that there's a heavy burden going to be paid physically and mentally, and probably for a long time to come, right? I mean, the world has moved on, but the stressors are still there.
Yeah. Well, thank you for coming in and tackling such a difficult subject for our members. And we're also grateful for those that have not engaged NACCHO. I'll put the website in there. If you're not a member of NACCHO or your health department is, we don't require it for AOS membership at this time. We used to before in the past. But if your health department is not a member of NACCHO, please consider it. It's just, they're the voice of local public health departments across the nation. And they take the time to really represent everyone. And so we're really grateful for the time today. Any closing remarks, Tim, before we go?
I don't think so, but I just want to, thank everyone. Part of what's made this research possible is that everyone, including those on this call, when we're reaching out, they're able to share those experiences. And as Aaron mentioned, this is really difficult to talk about. So we're really thankful that all of the public health staff from across the country are willing to talk about it so that we can try to study this systematically. And I thank you all for letting us come to talk about it today.
Thanks, guys. I'll send out the recording and also the contact information for Tim and Aaron. And thanks, guys, for your time today. Appreciate it.